glad those of you who couldn't get on or have now been able to get on. I'm glad to introduce Dr. Una Makris. She is the chief of the rheumatology section at VA San Diego healthcare system, and has appointments in not only rheumatology, but also geriatrics and palliative care. Una's been a long time clinical rheumatology researcher. She has some specific interests and expertise in older adults and geriatrics. And is going to talk with us today about a recent study of hers, moving to improve pain and depression in older adults. So Una, we'll let you go ahead and share your screen. And if you'd like, people can put questions in the chat during, and we can leave some time for questions at the end as well.
Wonderful. Can you tell me again if you see the presenter mode or the one that...
So this is, there you go. That's the one we want. Looks perfect.
Wonderful. Well, thank you, Dr. Allen. Thank you for the invitation to speak at your seminar series. I have no commercial financial relationships. I'm currently funded by a VA Health Services merit, and I kind of grew up in the VA system, having received the CDA-2 and then the merit, and also a GEM-STAR, one of the aging for subspecialists RO3s. The views expressed today do not reflect the position or policy of the U.S. government. So my overarching career goals, just to extend Dr. Allen's introduction, is I'm a rheumatologist with a research focus on aging. So I went through a T32 in geriatrics after I completed my clinical rheumatology fellowship. I'm a clinical investigator focused on improving outcomes that matter most for older adults with chronic musculoskeletal pain. And we'll be talking about developing high-quality, effective, non-pharmacologic interventions that can be feasibly integrated into care for older adults. Today, we'll talk briefly about the epidemiology of musculoskeletal pain among older adults, behavioral interventions, and then development, evaluation, and next steps for Motivate. So why is it particularly appropriate that musculoskeletal specialists focus on research that affects our aging population? The NIA predicts that a very large increase in disability will be caused by increases in age-related disease, and arthritis and back pain are among the top of that list. This has enormous implications for social support systems, resources, and our economy. We know that chronic pain prevalence ranges based on the care setting. So up to 80% of older adults over the age of 65 will report chronic pain. And we know that aging is a risk factor for chronic musculoskeletal pain. We know from the literature that pain in later life increases the risk for various adverse outcomes. I won't read all of them, but some of these include falls and fractures, depression, anxiety, social isolation, sleep disturbance, disability onset, cognitive deficits, frailty, as well as spousal or caregiver distress. And this project that I'll be presenting today focuses mostly on back pain. And why is back pain important? It's the most common chronic pain condition, second most common reason for an office visit. We understand the considerable morbidity, and this is now a dated estimate, but this is costly, exceeding over $100 billion in direct and indirect costs per year. And in the last decade or more, diagnostic and therapeutic procedures for back pain have really skyrocketed. However, patient outcomes have not yet improved, so we have a lot of work to do. I'll also be speaking about simultaneously targeting depression, so both low back pain and depression. And the reason why I focus on this is really, it stems out of my clinical practice. These folks are this overlap population is very time and resource consuming. They tend to be more refractory and perhaps a little more challenging to manage. What I tell my patients is if we don't acknowledge the comorbid mental health conditions, it's also very difficult to truly manage the pain. So when we think about conditions that are multifactorial, those with multiple contributors, interventions must be informed by the biopsychosocial model shown here. This is not new. I intentionally selected this figure because this actually really has been displayed in textbooks since the 1970s. However, uptake across different disciplines is variable. We tend to really focus on the bio and less so on the psychosocial. So we really, our current approach to chronic back pain and chronic pain in general is not always adequate. And we urgently need to identify effective therapies. However, especially in older adults, medications alone and surgery may be less appealing, and this is for various reasons, including multi-complexity, polypharmacy, 5 or more medications, frailty, fragmented social support systems, and we also know that long-term nonsteroidal anti-inflammatory medications are often contraindicated in older adults. We're also living through this opioid epidemic where the pendulum is perhaps swinging the other way, but we are all very familiar with the adverse events listed, and we have quite a bit of evidence that opioids are not more effective than NSAIDs for musculoskeletal pain, including spine pain. That was a publication, the SPACE trial from Aaron Krebs and colleagues. We also turn to guidelines, including the CDC, that suggests we avoid opioids for chronic pain as first line. The American College of Physician guidelines also note that first line are non-pharmacologic and behavioral interventions. And most importantly, patients are asking for something else. When I was a fellow, I did my clinical rheumatology fellowship at Yale, and I received a small grant to understand the psychosocial impacts of chronic back pain among older adults, a diverse older sample. So I would drive from New Haven to the Bronx. I would go to New York every week to several senior centers, and I would interview a diverse population. And time again, they would say, I don't want another pill. If I go to my doctor, they'll give me more medication or send me for surgery, and that's a gamble. So in many ways, they're asking for something else, something along the lines of self-management. Is there something I can do to help myself out? So we have existing behavioral interventions. We know that cognitive behavioral therapy for chronic pain, especially at the VA, there is a massive rollout of CBT-CP. When I was putting together my career development award and the focus of this project, some of the colleagues in the field felt that perhaps cognitive restructuring would be challenging among older adults. We have mindfulness, we have Tai Chi, we have yoga. There's robust literature on physical activity, not just on the actual activity, but also with implementation guides. And I point to the OA Action Alliance, which is fueled by many of you. I've been teaching our residents and fellows for years and actually point to your material. So thank you. I kind of really look to you for very easy to digest material for both us and for patients. However, very few interventions have focused exclusively on older adults or those with comorbidity of physical and mental health conditions. In 2015 or 2016, I was honored to be invited to participate in VA HSR state-of-the-art conference focused on non-pharmacologic approaches to chronic musculoskeletal pain. And this is a slide from Aaron Krebs, one of the takeaway slides from this SOTA, and that is that we have many implementation ready, meaning we have sufficient evidence for many of these therapies, manual therapy, behavioral therapies, movement therapy, and that different approaches have similar efficacy and no one approach is effective for most patients. So I, in my practice, really like to have a toolbox of options that I present to patients, and many of this the issues boil down to access. And so I'm grateful to work at the VA that tends to have access to most of these. So with this, I'd like to move on. This is a patient. It's a very common kind of scenario that I see in my clinic, and it's for Mr. L and all of the Mr. L's that I created this program for. This is a 78-year-old gentleman with 20 years of episodic low back pain, no radicular symptoms. Bending, lifting exacerbate the pain. He rates the pain as 7 out of 10, but more importantly, linking function to that pain score, he's unable to garden all afternoon as he used to, as he likes to. He avoids church. He's worried about spasm, and he declines offers to see friends, maybe leading to more social isolation. He has poor concentration, occasionally feeling hopeless and lonely. His grandkids are very busy and rarely visit. He has tried everything: PT, chiropractor, Tylenol, NSAIDs, tramadol, opioids, epidural, steroid injections. His exam is unremarkable aside from a thin gentleman using a cane. He has some paraspinal muscle spasm, right greater than left, and bony hypertrophy of the knees and of the small hand joints consistent with osteoarthritis. Further assessment indicates a PHQ-9, which is a depressive symptom scale, of 14, which indicates moderate depressive symptoms. So this is a very common scenario in my clinic. And so for Mr. L, we created this novel intervention that really builds on prior work and prior evidence. We call it Motivate, moving to improve back pain and depression in older adults. And the goal here is to develop, adapt, and evaluate a telephone-delivered behavioral intervention for older adults with the comorbidity of back pain and depression. One of my mentors has been Anand Nayak at the Houston VA, and they developed, along with Jeff Cully, this intervention building on healthy outcomes through patient empowerment that focused on comorbid diabetes and depression. And so here we are focused on back pain and depression. The core components of Motivate are that include behavioral activation using principles of motivational interviewing. So instead of a CBT for chronic pain, we really felt that motivational interviewing would be useful, and we'll talk more about this in a few slides. The underlying premise here is that goals consistent with values will cross-cut both physical and psychological diagnoses. We really focus on how older adults are uniquely motivated to make and sustain behavioral change. And as Dr. Allen mentioned, I'm very passionate about aging. I consider myself a little like a geriatric rheumatologist. And so this really nicely aligns with the concepts of geriatric 4Ms or 5Ms. The geriatric 5Ms were actually introduced by the Institute of Healthcare Improvement and adopted this age-friendly healthcare system initiative to essentially enhance the likelihood of providing high-quality care to older adults. So IHI developed this, and then American Geriatric Society added one more M, which is multi-complexity. The other M's include mind, mobility, medication, and what matters most. So I really consider Motivate an age-friendly approach to both pain and depression in older adults. So let's speak a little more about motivation and physical activity. Motivation is defined as the driving forces responsible for initiation, persistence, direction, and vigor of goal-directed behavior. These investigators evaluated 89 studies assessing changes in motivational constructs for physical activity, and these included intention, stages of change, and autonomous motivation. And they found that the behavioral change techniques that were beneficial include behavioral goal setting, self-monitoring of the behavior, behavioral practice and rehearsal, and that increases in intention and stage of change were significantly related to increase in physical activity. And so that's really what we work on with Motivate. A little more about motivational interviewing, and I will say that MI is something that we need to be trained in, but then we need to practice how to use MI and occasionally receive booster sessions. So motivational interviewing is a collaborative, person-centered form of guiding to elicit and strengthen motivation to change. I would argue we all need this, whether it's at work or at home. This is a method used for a particular purpose to help people resolve ambivalence and move towards change. It originated in substance use disorder treatment, often used with tobacco cessation, for example. It's been used in over 200 RCTs, and the trials encompass a wide variety of target behaviors. It is considered an evidence-based treatment, but it's not recommended as a manualized treatment. So in Motivate, we really use components of MI. The processes of MI include engaging, focusing, evoking, and planning. And all of this is used to collaboratively work with the individual to help promote change. This is a schematic for how our coaches in Motivate identify values. So the patients come up with 5 values. The coach works with them to link physical activity-based goal to one of the values, and thereby we hope that we have motivated the patient and activated them to make and hopefully sustain a behavioral change. This is our conceptual model for Motivate. This is a model pathway by which our behavioral intervention is hypothesized to improve the behavioral here in the middle and ultimately the clinical outcomes on the far right. So we target the behavioral factors and determinants in red at various points during the Motivate intervention, and thereby hope to improve engagement in a health-promoting behavior, in our case, physical activity and steps, and ultimately improve clinical or more distal outcomes of pain interference, depression, and hopefully function in the future. So I'll walk you through how we created Motivate in phase 1. We developed this telephone-delivered behavioral intervention that targets older veterans with back pain and comorbid depressive symptoms. It is all delivered over the telephone. This was all kind of created around 2016. So this was pre-COVID, but it really turned out to work well during COVID because we didn't have to pivot from an intervention standpoint. We know that telephone health coaching may be very appealing, especially to improve access for those who are mobility limited. And we know that the types of client-selected goals most often met with telephone coaching include physical activity, emotional health, and pain management. So Motivate is delivered over 8 sessions over approximately 10 to 12 weeks. For Mr. L, this is particularly ideal and appealing because he lives near the border with Oklahoma. So when I was putting this together, I was in Dallas for about 15 years, so Dallas, Texas. And so Mr. L was in Oklahoma, which was about 3.5 hours to come see me in clinic. There's really no reason to bring him over to my clinic for something like this. And further, in rural areas, there are rarely behavioral services that Mr. L can access. So we were working with Mr. L in his own home and moving towards more video home technology. So this is an outline of the session content 1 through 8. In session 1, we really introduce the program and kind of establish rapport and expectations and talk about baseline activities and how back pain and depression kind of impact that individual. In session 2, we talk about what is most important to you. We called this values elicitation. The veterans didn't like that title, so it's really what is most important to you. Setting sessions 3, 5, and 6 are setting and planning goals that are really SMART goals, where they identify a physical activity goal linked to a value, and then they have 2 weeks to practice that goal. I thought initially that session 4 would be optional, This one focuses on challenging thoughts and beliefs, really tackling the maladaptive behaviors. And so really everyone needs that session. And then sessions 7 and 8 are kind of winding down and highlighting skills that have worked and training the individual how to practice these skills once this program is over. We developed in phase 1 Motivate by assembling various groups, including experts, patients, and other stakeholders that really informed intervention content and delivery. So we may have interviewed several of you back then to help us develop the program. We conducted semi-structured interviews using the parish implementation framework to inform topics based on the specific group we were interviewing. So experts focused on the conceptual model, session order, outcome assessment, and timing. Veterans really focused on messaging, the wording of the content. That was probably the most useful to hear the veteran perspective. And then we interviewed other stakeholders, really keeping an eye for implementation as we developed this program. In phase 2, this was really a single arm rollout where we pre-tested the intervention in a smaller group of veterans with the target population. We hired and trained the health coach, and we really wanted to understand, can we do this? We recruited both men and women over the age of 65 with low back pain for most days over the past 3 months that interferes with daily activities. We had a threshold for depressive symptoms with the PHQ-9 of greater than or equal to 10. That's the cutoff that's considered kind of moderate, where we would actually act on managing the depressive symptoms, and they needed to be capable to participate in a home-based physical activity program. I am very concerned, of course, with other comorbid medical conditions because we don't see these patients in person. We excluded individuals without a telephone, with uncorrected hearing or visual disturbance, with the rationale that that would increase the risk of falls. With moderate to severe cognitive impairment, really they had to be able to walk still. We also excluded folks who had very severe mental health disease that would really require them to focus on their mental health rather than this behavioral intervention. The outcomes for this stage of the project were really feasibility. What were the recruitment rates? Could we deliver this intervention with fidelity? What were the number of sessions per subject, the average time per session, potential harms and risks? We didn't talk about this, but we would mail them a pedometer on a career development award budget. I could afford an Omron pedometer, so that's what we sent them. And really, can we capture steps per week and the impact of back pain and depression using this paper and pencil tracker that we created? Other outcomes of interest that we would assess in a future trial would be pain interference, self-reported disability for the back pain study, Roland Morris disability, and then depressive symptoms with the PHQ-9. Prior to this study, I did a few studies really diving into patient-reported outcomes and kind of legacy measures. So we do include the NIH Promise instruments. We've included Therapeutic Alliance, a contemplation ladder. I'm very interested in concepts of psychological and physical resilience. Here we use the psychological resilience CD risk. And then we're actually also capturing data on healthcare utilization, including medication use, ER visits, hospitalizations, as well as rurality within the CPRS CDW kind of VA records. These are the timing of assessments and intervention sessions. Here at the top, we have telephone delivered sessions delivered by the health coach. Sessions 3, 5, and 6 have 2 weeks in order to practice the goal. All other sessions have 1 week in between the telephone calls. And then we have a research team and blinded kind of assessments at baseline, mid, end, and then 6 months. So the progress to date for Mr. L, he identified the following goals: being physically present as a good grandfather, friendship, connecting with nature, he loves to garden, spirituality and religion. The outcomes that we anticipated would improve were step counts, readiness to change, depression, self-efficacy, and social isolation. He had a strong working alliance with the health coach. And the questions were, could he sustain these behaviors? The health coach really encouraged the participants to engage in their existing social circle, whether it was his grandson or his church friends. So in phase 3 of this project, we conducted the pilot RCT to assess again for feasibility in the context of a pilot, where we assigned subjects to receive either Motivate or a comparator, which we decided would be a waitlist control. And here we looked at feasibility and trends in outcomes. This is the overview of the pilot. We recruit, we do a baseline, we randomize to either the waitlist or the Motivate, and then we conduct the blinded mid and then follow-up assessments. These are the results from the pilot study. We enrolled 50 subjects. The recruitment rate was about 11%. Very hard to recruit this population. We learned a lot about recruitment. We really found that the more effective way is this opt-in, opt-out, IRB approved protocol. Many of the reasons for screening out, they weren't depressed enough. We had a threshold for movement, and we ended up dropping that. So all of these things are great for this patients, but really tough for recruitment. And ultimately, a huge portion of those approached were simply not interested, did not have enough time to participate in research. This is the consort diagram, really based on where you cut it off. We had the recruitment rate of anywhere from 11% to actually 18%. So not too bad. These are baseline characteristics. Our average age overall was 71%, and then we list the control and the Motivate arms. We were able to recruit 20% women, which at a VA is great. We were very proud of ourselves. We have a diverse population with 50% white, about 40% African American, 8% Hispanic. About 20% lived alone. And interestingly, they lived approximately 30 miles from a VA, including the community-based clinics. I've listed the BMI, the Charleston, which is a comorbidity index, and here are the baseline PHQ-9 depression scores, PEG-3, and Roland-Morris. At baseline, the average step count just for the Motivate arm was about 2,400 steps per day. We found that the intervention was feasible. The pedometer was easy to use. The step counts increased by session 5 to about 4,300. Again, that was an intermediate outcome, not really a more primary outcome. We used step counts basically for the coaches to use this as a data point to move the conversation forward. The veterans were able to use the tracker, and they reviewed it with the health coach. This was very cumbersome, and I reviewed all of the fidelity audio recordings, so just listening to this was very cumbersome. They really engaged well with our coaches. The coaches used the MI skills of cultivating change talk, softening sustained talk, partnership, and empathy, and then I would provide feedback to the coaches to prevent drift. These are some of our preliminary results, just trends, truly trends, no p-values. Here we have kind of averages in blue. We have the Motivate in orange. We have the control group. So the far left top is the PEG-3 pain interference score. And you see that both groups start around 6.7, and the Motivate group drops to about 5.1 at the end assessment. It's about a 1-point difference between the control group and the Motivate group. And what we're thinking is clinically significant is about a 1-point difference. Again, we see an improvement in the PHQ-9. That was more striking to me. So PHQ-9 in the Motivate group here in blue dropped below 10 to 7.4. The control group was 10, and again, there was about a 5-point difference between baseline and end for the Motivate group. So we see trends in improvement also for the disability score, for this physical function promise score. We see improvement in self-efficacy. Resilience is a little tricky, but we see some improvement. Again, trends, just trends in improvement for pain catastrophizing, stages of change, social isolation, and some small changes with sleep disturbance. So we took these preliminary trends and applied for the merit, the next grant. I don't know how many trainees are in the audience, but I'm a multiple submission type of girl. So on the third trial, on the third submission, I got funded. So we are currently, conducting the larger scale trial for Motivate. And so what we proposed was a hybrid type 1 effectiveness implementation trial, where we're testing in AIM-1 the effectiveness of Motivate versus a waitlist control. We originally aimed for 264, where we recruit in 2 large facilities, both Dallas and Houston. And actually, our attrition rates were a little lower than we thought. So we received approval to drop that to 206 as a sample size, and we just met that, which is very exciting. Maybe a week ago, we just completed recruitment. We dropped our eligibility age to 60. We expanded from back pain to all musculoskeletal pain. So we're including osteoarthritis and fibromyalgia, plus the depressive symptoms. And again, can we capture steps, pain, mood using technology? We've integrated this texting program through the VA called Annie, where we try to kind of assess more dynamic variables. AIM-2 is an implementation aim where we're evaluating kind of barriers and facilitators using the iParish framework. And then in AIM-3, we're doing a budget impact analysis. So we have a health economist who is going to help us quantify the costs of both Motivate and the control arm. Just want to see how I'm doing with time. I'm not going to go through this. This is just the standard table of outcome measures and data sources that I just want to highlight for any trainees who are joining. Having a pilot program is essential to work out the kinks and smooth out the process to figure out what is absolutely needed and desired for the larger trial. And so our primary outcomes are really pain interference, and then secondary outcomes include the PHQ-9 and all of the other outcomes listed here. These are some pages from our intervention manual. The VA has a wonderful medical media program. And so I really pulled these out. These are pages where we emphasize social support and sustainability. Find friends and family to do the physical activity with in order to sustain the behavior. We talk a lot also about successes and maximizing on lessons learned. We also have a very robust safety and suicide assessment protocol that aligns with our national and local policies for suicide prevention. And then our team is very well trained in the suicide protocols, because really we're assessing all of this over the phone. We're asking the PHQ-9 multiple times. And so we have a lot of protocols in place. So I want to kind of wind down and just highlight how, probably the most gratifying aspect of this project is the continuous engagement with veterans and other stakeholders, of course, but really throughout the process, we engaged the veterans and other experts in the field, and then iteratively refined Motivate after AIM-1, after AIM-2, at AIM-3 in order to inform the current trial that we're doing. And now I have ideas on how to refine it further as we hope to scale up. So I already talked about the geriatric 5Ms and how this really is kind of an age-friendly approach. But the other nice aspect of Motivate is that it aligns with another initiative at the VA, which is whole health. Whole health is inherently also very age-friendly if we're dealing with an older adult population. So again, putting the veteran at the center. And so what's really important about the whole health initiatives at the VA is that they have invested heavily in whole health coaches. So that would be my dream if we move forward, that we can train whole health coaches from a sustainability standpoint. What are the implications and future directions? Again, just to revisit, my overarching goal is to develop high quality, effective, age-friendly interventions that can be feasibly integrated into care for older adults without placing additional burden on healthcare providers. So I'm not asking the busy PCP to do any of this. In fact, if they have the opportunity to refer to us or to a coach, they are doing cartwheels. They are very happy. I aim to improve access to adjunctive behavioral options developed within for older adults, and really feel strongly that coaching can augment the care received in primary specialty and mental health care. How can we incorporate technology to capture dynamic variables and assist with sustainability? And then how can we use the social environment to help sustain behavior? I really love that we were doing this with the veterans in their own community and home rather than bringing them into the health setting, the medical setting. So I want to thank many people, including my Dallas VA and UT Southwestern colleagues, the UT Houston School of Public Health. I have my biostatistician team at the West Haven VA. Bob Kearns has been very instrumental in developing me and my ideas. Carrie Reed is one of my colleagues and mentors. And so thank you to all. And thank you to the VA partners. That's another really fun aspect of working at the VA and doing research at the VA, is that you get to know the operations partners, whether it's in geriatrics, extended care, mental health, and suicide prevention. And really, they start working with you because they see kind of a glimmer of hope in your ideas that can really help many, many veterans. So I'm looking forward to the next step. This is my team. I spend a lot of time thinking about the diversity of my team. This is Nicole Brown pointing to the percent of women. She is passionate about enhancing the female participation of veterans in studies. So she's been great. I've been working with her for almost a decade, and she's also my coach for the Motive. She coaches me probably, but she's the Motivate, one of our Motivate coaches. So with that, I wanted to thank you for your time, and I'm happy to take any questions.
Thank you, Una. It's great to hear a lot of your story behind this study. Lots of applause. Una, do you want to stop sharing so we can have a little bit bigger pictures of each other? And for those of you who are interested, you can feel free to come off camera. You don't have to. I don't see any questions in the chat yet. Feel free to raise your hand or just chime in. Okay, one question: ratio of men or women using VA services. What is it in the VA, Una? It's the proportion of women is it like
It's like 5 to
10? Yeah,
10%.
I was going to say
Yeah,
10. Yeah, so it's pretty low.
it's
It varies somewhat across VA settings, but
and it's increasing, especially with younger women. But because we're targeting older women, it's more challenging. However, older women love us. They want Motivate. They want a behavioral intervention. It's really hard to actually, we're not in the business of convincing, only motivating. And men, nah, I'm not interested. I'm too busy. So it's hard to get men engaged as compared to the women.
I completely understand. My husband is in the VA, and he went up to DC at Bethesda, and they tried to recruit him for multiple research studies. And it is really difficult to keep men engaged. I'm sure the participation might be higher within the older community compared to maybe younger men, but it was a great presentation. I really loved I really loved what you do. Thank you.
Thank you. Thank you.
Caleb, I saw your hand.
I'm just, first of all, impressed, Una, that you're here so early
I mean,
in the
I look
morning.
like this, you all. You bared with me. Yes,
You look great.
it's really.
My follow-up, so I ask a lot of questions to our participants, and we get very much a large amount of participation bias. And your inclusion criteria is pretty high. But then, in order for people to, I mean, that's a lot of things to go through and a lot of tough questions to ask on a regular basis. Um, I'm just getting a sense of, I guess, your placebo arm or something helps to get an idea of that. But I'm wondering about generalizability and applicability to people who, um, beyond the trial, um,
Yeah.
and the motivation side, or is it just sort of somewhat on purpose self-selected because these are folks who really actually want to do something to get better?
So Bob Kearns encouraged me to ask, I think, one of the key questions as we were recruiting for this trial. And his question was, don't you want to ask a question about, are they interested in a non-pharmacologic approach? Are they interested in? So that's one of our questions. We don't get a lot screened out, but I think some of the folks who say, I'm not interested, maybe deep down, that's part of the reason. Either they have more, they don't have enough time or they have too many comorbidities. But there's absolutely a selection bias, and it's difficult to recruit because of such strict criteria. And so from my standpoint, I'm kind of answering a slightly different question here, but as I think about next steps and scalability and making this more generalizable, what aspects would I want to drop, right? That's what I'm all thinking. And so I'm now in the process of interviewing the people whose hands I want this in. Which population are you trying to serve, and how can we capture them so it's not so burdensome for you to identify the appropriate target? And so I will add, for the purpose of research, and we all know when we're designing studies, we need thresholds, and you don't want to dilute that delta to it. You want to do this in an ethical kind of scientific way, but keeping that PHQ-9 threshold of greater than 10 makes me feel quite good that I'm going to see a delta there. If
Yeah.
I drop that and now open the floodgates to everyone who has maybe some subclinical symptoms, that will look very different, right?
I
But
mean,
I
I
think I
guess
need many, many more patients, and I still think they would improve. But from a research standpoint, how much would they improve? And
yeah.
maybe the outcomes of interest for a future more pragmatic study would look different.
I think those are my two quick comments for you. Is one, our experience here is that the men in the VA are happy to participate in our research as long as they don't have to ask too many questions.
I know.
So and the second is I'm wondering about all of sort of the left censoring of people who actually got help, who were on antidepressives or other sort of therapeutics that actually brought that score down, that they may have qualified at some point as well, and who may not be as helpful treatment as they could be as a possibility. But that's for future discussion. I really appreciate your talk.
Thank you. It's so good to see you. Yeah, and we're
Really?
capturing all the medications, so we know. But still, if they hit that score, that was a question, Dr. Allen, I may have asked you in the past. The threshold for physical activity. If they're already walking a certain amount, would this intervention help? And the point is, if they're scoring high on the PEG-3 pain interference as well as the depressive symptoms, maybe walking even more, or maybe it's the attention spent on identifying values and goals. Maybe the work spent getting to that point is what makes all the difference.
Yeah, because you have a multimodal approach.
Yeah.
Lee has a question.
Yes, thanks. Very interesting talk and very carefully done research. My question is, it feels like the VA is in many ways kind of ahead of the curve with certain things. Like I know they have that move, and now you're working on this project. How transferable or generalizable do you see this to other healthcare systems that aren't I don't know if you call the VA a closed healthcare system, but it seems to be more it feels like that you can do things there that maybe wouldn't work in other settings.
Absolutely. I agree with that. So the VA is a special place as an integrated health system, one of the few with Kaiser and so forth being others. But the VA is a special place to do research, and I'm so fortunate to receive funding at the VA. So developing it at the VA is the way to go. But I'm very interested in scaling up and adapting it to other populations. And I attempted to do that, and I'll say I kind of failed. So we tried. I received some kind of institutional money at UT Southwestern, and I tried to integrate this into the safety net hospital. So I hired a coach on the university side. I said, well, I developed it for a highly comorbid, very sick, complex population at the VA. Let me do this for another complex population at Parkland Hospital, which is our safety net. Failed completely. Not failed because we couldn't recruit. And so the issue is veterans tend to have a little more housing security, and they tend to pick up their phone more. And so they wouldn't answer the phone when we tried to recruit on the safety net on the Parkland side, and they would move houses often. And so that approach did not work, and I didn't have enough funds through the institution to modify. But I still feel that this should be useful. It just we need to spend some very careful thought adapting it for the different populations. Again, talking to that population, seeing what might work. And we started to do that process. I also tried to recruit from the actual university clinics, and we found that the white women were too optimized for this. And they just couldn't meet our thresholds. And so that's when I moved to the safety net. So very much an interest of mine, but it needs a lot more time and effort to adapt.
Well, maybe once you have the cost effectiveness data and the fact that it is remote, then maybe even if more monies were spent trying to recruit people from the safety net population into the program and you could be successful, it would be effective.
That would be a dream. I do think the budget impact analysis will speak for itself as long as the trial itself is let's see what the outcomes are. What I'm finding a lot, and you might see this in your studies, is, you have the outcome data, but then you have the qualitative data, and the qualitative data is very robust. And there's some it's not completely congruent, but people are saying they love it. They love it, love it. They want more of it. But then the outcome data suggests it's better, but maybe not that much better than usual care. Let's see. Yeah.
Katie.
Thank you. That was a great talk. And thank you for your plug for the OA Action Alliance. So one thing that we have been doing at the OA Action Alliance is trying to integrate a behavioral intervention. And we've tried it in a few different locations. So I'm just interested in your perspective on where this type of intervention might be best placed, whether that's in a rheumatology setting or primary care, like where it's being driven. And how patients will view it, whether they're coming at it from the rheumatology perspective or from a primary care perspective.
That's so I am a primary care doctor when I talk about this. So my rheumatology colleagues don't always understand and love this concept. And I haven't yet recruited from rheumatology clinics. In fact, sometimes I've excluded inflammatory arthritis. And so this is really based out of primary care. This is to help the masses, so to speak. But I don't see why it wouldn't help our patients in rheumatology clinic. I would love to see this in the community. I'm talking to some folks. Can we roll this out in a senior center? I think anyone with these comorbidities, which are incredibly common, would serve to benefit, so long as there's an infrastructure with some type of coaching mechanism. And I didn't talk about the training of coaches and who the coaches are and the prerequisites for the coaches, but you can train many different types of people in this type of coaching that uses MI.
All right, well, we're at time. Thank you, Una, again for your preparation for this and for talking to us about this. And I hope this will be spark some future collaborations. I have a handful more questions for you on the VA side about downstream implementation, so we can talk at some point. But yeah, this has been great. And thanks for everybody for your attendance.
Thanks so much. Take care.